submitted our request for accreditation for CPD points to the HPCSA in January already, and paid for it. There has been some administrative delay, and it seems as though the CPD points for our last webinar a few weeks back have not yet been allocated. And so there might also be a slight delay with CPD points for this one. Please just bear with us. If you do have problems with it, just email us and we'll see what we can do. But it ought to be sorted out very, very soon. Those of you who are registered with HPCSA, you don't need to do anything other than to have completed the registration, and we will arrange your CPD points for you. As usual, we will start off with some presentations. There'll be some time for discussion, and then afterwards we will take questions. We ask you, please, as usual, to type your questions into the Q&A box so that we can respond to as many of them as possible and keep the questions hopefully quite short. As with our last event, our focus is on the funding cuts of the US government, which have affected both, obviously, clinical work as well as have affected research. Our focus, initially at least, is going to be deliberately more clinical, but clearly in the light of further announcements of cuts to research funding, we accept the reality that you can't separate these easily, and so we'll allow and be open to discussing the effects of both. Slight change in focus this time. Last time we looked at impact and implications. This time the focus is a little bit more on government's response, and ultimately what we hope to get to is some sort of recommendations in terms of what our government's response ought to be at this time. So thank you once again for joining us. I'm going to start off by going quickly through the bio sketches of all of our participants so that we can then just get on with the business and why people are still joining us. I think that's appropriate. So our first speaker is going to be Kate Rees. She's a doctor and a public health medicine specialist at Inova Health Institute. She leads programmatic innovations, conducts impactful research, and manages stakeholder engagements in both HIV and TB care. She is also co-chair of the South African AIDS Conference for 2025, and she fosters effective collaborations and advocates for policy improvements, driving meaningful advancements in public health outcomes. Dr. Ashraf Grimwood is a doctor and a public health expert. He is the founder and CEO of Ket Impilo, a nonprofit organization that provides innovative solutions to clinical care and treatment services, health and community system strengthening, and social facilitation. The organization is a leader in public health and social services innovation, working towards migrating the social and health impacts of the triple disease pandemic impacting on disadvantaged South Africans. Fatima Hassan is a human rights lawyer and social justice activist. She's the founder of the Health Justice Initiative, and she has dedicated her professional life to defending and promoting human rights in South Africa, especially in the field of health. She has previously served on several NGOs and other boards, and currently serves on the advisory group for Resolve to Save Lives, as well as the University of Washington Department of Global Health Partner Advisory Board. And then facilitating the event today is Professor Amy Stye, who of course needs little introduction. She's the founder and past director of the Steve Biko Center for Bioethics and a professor in the Wits School of Clinical Medicine. She's also the immediate past chairperson of the UNESCO International Bioethics Committee. She has served on countless international and national commissions and advisory panels and committees, and is consulted to the World Medical Association, the World Health Organization, and UNESCO, and many other organizations. And throughout her distinguished career, she has taken a lead in health advocacy and activism. So having introduced our speakers, I'm now going to share a very short introductory PowerPoint with you, and then we'll proceed from there. This is a brief introduction. I just wanted to point out just some of the implications of the withdrawal of funding, and particularly focusing now on PEPFAR funding, which, as you know, largely affects HIV and TB patients and others involved. And an interesting paper that was published in February in the Annals of Internal Medicine, Gandhi, Becker, and Peltier et al. Had done some research considering the possible impacts of any cuts in this sort of funding, thinking of it at that point as a future possibility rather than a reality. And they did some modeling. As it turns out, the first cuts, in fact, happened days before this paper appeared. But just some of the facts that emerge based on this modeling is that if you consider a situation in which PEPFAR funding remained at 100% for the next 10 years and compared it to a situation in which there was no funding, there would be a difference of some 636,000 likely new infections. That would be an increase of 65%. They're predicting that without PEPFAR, there would be a difference of 601,000 HIV-related deaths just in South Africa, and also without PEPFAR, that those people who are living with HIV, that their life years expected would drop from 22.71 on average to 19.0, a drop of 16%. In the same paper, they also pointed out that if you have a look at people currently with HIV, that if in 5 years' time with PEPFAR funding, we would have expected to have reached about 95% of all people with HIV actually being diagnosed. That would drop to 92% in just 5 years without PEPFAR funding. 85% of those who would be diagnosed would then be on ARVs. That would drop to 73% after 5 years without the funding. And those 90% would have been virally suppressed if they had with the funding, and without funding, that would drop to some 88%. So even though it's only some 18% of all the money that's spent on HIV treatment in this country, we do realize that this withdrawal of funding will have a huge impact in this country. Just quickly having a look at the global situation, one of the UN agencies that deals with HIV was saying that they expect 6.3 million additional deaths in 4 years, and about 8.7 million additional infections. So that just kind of gives the background in terms of what the impacts are likely to be. And with that, I'm now going to hand over to Prof. Dai, who will lead the rest of the session.
Thank you. Thank you, Kevin, for painting this context so well. And I must say, indeed, these are very stressful times. And especially when you're looking at HIV, TB, gender-based violence, prevention and management. And of course, healthcare in general in the country. I also think that it is really fitting to have this discussed as an Ethics Alive activity because of all the ethical and human rights issues that are raised by the many complex scenarios that we see emanating from this withdrawal. And I also think we must take into consideration the vulnerability of our patients, our communities, and our country at large as well. It seems like government doesn't seem to infer that this is a big deal. You know, that's just not right. And you know, as far as government has been concerned, and the responses that we see from state players is that it represents about 17 to 80% of South Africa's annual budget, and this can be plugged. But we haven't actually seen what's going to be done to plug this. Now, Kate, you've been very involved in PEPFAR management, you've been very involved on the site in terms of delivery when it comes to PEPFAR. What does this mean to the health system in general? Would you like to discuss that with us, please? Over to you, Kate.
Thanks so much, Prof, and thanks for having me. So as Kevin kindly introduced me, I work at Inova Health Institute. We're a local South African NGO that was founded in response to the HIV services need to support the Department of Health, and we've been doing so through PEPFAR and USAID for more than 15 years. Because we have an estimated 8 million people living with HIV, this response really requires an all-hands-on-deck approach. Any health system would find it very difficult to handle getting treatment to all of these people. And of course, we also need to think very carefully about ourselves as members of Sub-Saharan Africa, of the region, and how this freeze is going to impact on the whole region. But I'm just going to speak briefly to the changing role of PEPFAR in South Africa, and then touch on 3 really important impacts. Firstly, in terms of service delivery, then staffing and community-led monitoring. So in the early days of the HIV epidemic, I think we all remember that denialism created this huge vacuum, and PEPFAR was created as a global response to an emergency with its epicenter in Sub-Saharan Africa. Over time, the need in South Africa shifted. South Africa was able to take on the purchasing of its own art, was able to decentralize services, task shift services, and create good systems for task shifting, all with the support of PEPFAR. And more recently, PEPFAR has been plugging gaps in the South African HIV response. So, for example, providing services to key populations, or quickly implementing new innovations like differentiated service delivery and PrEP, for example. But there's also been a lot of technical support at national, provincial, and district level, enabling improvements in things like supply chain, health information systems, data utilization, and so on. Over the same period, health systems gaps have remained or even worsened in provincial and district health services. And some, of course, as we know, have serious governance concerns, and there's poor access to care for many people. PEPFAR-funded NGOs, on the other hand, have had to maintain high governance and performance standards to continue to receive funding because of the United States government's requirements and also the competitive funding environment. So in some ways, that has enabled better performance. Of course, there are plenty of problems with this model, and I think the really important ones are that it may foster competition instead of collaboration, the potential for duplication, and the potential for parallel systems instead of strengthening government systems. So despite these concerns, all of this is to say that although PEPFAR funds 17% of the HIV program, in fact, the impacts of PEPFAR have been far greater than the 17%. So the first category I'm going to talk to are some of the services that have been most impacted and will be most impacted. The first is PrEP, which is highly visible. South Africa does provide oral PrEP, and that's fantastic. What we are unable to provide, and what USAID has been doing a lot of, is the rest of getting the PrEP to the people. So the demand creation, the peer support, community services, that has all been severely curtailed. And we know that a lot of long-acting PrEP projects funded by USAID have been stopped, which is a real blow. Luckily, Global Fund has committed to continuing to implement long-acting PrEP, but still, it's really difficult for prevention in South Africa, but also globally. The next area is key populations. So by definition, key populations struggle to access standard services. So suddenly cutting off the services to these populations is likely to have a really negative impact on our progress towards eliminating HIV. We know that although we have a generalized epidemic, modeling studies show us that if we don't decrease transmission within key populations, we are not going to be able to decrease transmission in the general population as well. Beyond prevention in key populations, one of the important areas in terms of services is advanced HIV disease. So although most people living with HIV in South Africa are doing really well, because of the high numbers of people, we actually have a lot of people who need more advanced clinical and psychosocial services, which PEPFAR and USAID partners have been really instrumental in providing at primary care level through capacity building and mentoring and hotlines and other avenues. A specific population within that group is high-risk pregnant and breastfeeding women, and NOVA in particular has had several clinics that have stopped their service in this area, which is very likely to lead to increased vertical transmissions, but also poorer maternal health, and also possibly transmission of drug-resistant strains, which is highly concerning. And then access to data and data quality, which is so important to run a health service. Our health information systems and data capturing were really heavily supported by USAID. That includes not just capturing, but things like data visualization, data use, data quality assessments, a lot around the implementation of health information systems. So of course, there are a lot more impacts within the services that will be felt, but those were the ones that I really wanted to highlight. Just want to talk briefly to staffing and say that PEPFAR partners have introduced cadres of staff that are not aligned with Department of Health roles. And so on the one hand, this really highlights the problems with the funding model as it has been. But on the other hand, it's an opportunity for Department of Health to really improve on and work on some of the existing challenges. So two of the things that I'd like to mention are middle management roles, particularly management of counselors and management of data capturers. So I'm talking about people of performance management, which is really critical, but also allocating staff according to data, driving improvement and innovations, and also quality assurance, all of that. And then the second category of staff is psychosocial staff. This includes social auxiliary workers, child and youth care workers, lay counselors. In fact, retention on ART was the biggest problem in South Africa in our HIV response before this crisis. So psychosocial support is really essential to many, many patients whose mental health and social challenges are not being addressed within the existing system. And this all contributes then to poor adherence. Finally, I wanted to talk briefly to community-led monitoring, which has been funded by USAID and enables a really important early warning system, which tells us when people's needs are not being met. And ironically, this crisis has really shown how important and impactful community-led monitoring really is. And it's just really frustrating because the systems and the services Rishita has been building up has taken a long time to get to a point where it's of benefit to the Department of Health. And so it would be a real shame to lose all of that. So we know that the curtailing of PEPFAR is going to lead to huge gaps in service delivery and health system strengthening in South Africa. And the challenge is for the government is to respond to this crisis in a way that maintains as much as possible of what we have built together, recognizing the weaknesses in the Department of Health systems and strengthening them, rather than ignoring them and trying to brush them under the carpet. So my recommendations briefly are that we need stronger emergency transition planning, including funding, of course. And of course, we're not going to be able to replicate the scale of the US government funding, but we can't afford the paralysis that we seem to find ourselves in. And prioritization is really key to moving forward. We need to use this transition period to understand which cadres of staff should be integrated or absorbed into the Department of Health, and how to really integrate community health workers into the services. And we need to really learn from the current gaps that we are seeing. These are health systems weaknesses that urgently need to be addressed if we want to build a system that can run NHI. So things like health information systems, community-led monitoring, community-led or community participation, and management of healthcare workers. And to improve these gaps is going to require addressing major governance issues at district and provincial level. And finally, some key services essential to managing the HIV epidemic cannot be delivered through public sector services and need to be provided in the community. So, for example, key population and prevention services will always need to be provided outside of the clinic. Which means the role of NGOs and civil society remains really important, and we need to be meaningfully engaged in order to maintain and build the HIV response going forward. Thank you.
Thanks. Thank you so much, Kate. And I particularly like the fact that you've come up with recommendations that have put responsibilities on us within the country, you know, and in this way, also highlighting what government's responsibilities are. So in other words, you know, as a country, we've got to be self-reliant. We can't continue being over-reliant on foreign funding, whether it's from the US or elsewhere, because there's a huge lesson to learn now. Thanks. I'm sure there's going to be much discussion during the Q&A time, but I think we'll move across to Ashraf now. And Ashraf, on the 11th of February, there was a circular that was issued by the Director General of Health outlining the department's contingency plan to respond to the temporary suspension of support of PEPFAR and its implementing partners. I didn't see anything further after that tsunami hit us when there was a full suspension. I'm not too sure if you've seen something, you know, looking at how to address the issues in real time now, and then also look at long-term plans as well. So that's one. But also, you know, you practice on the ground. You are interacting with patients that have suffered the implications of this PEPFAR withdrawal. Do you want to share some of your experiences with us, and then if you could talk to us about contingency plans, the role of SANAC as well, and where is government in all this, please? Over to you, Ashraf.
Thanks, Prof. So let me just start off with a couple of days ago, I've had two patients come and see me, both very distressed. One was a 56-year-old teacher, male, who'd been getting his treatment from a men's clinic in Cape Town, and he'd been traveling from his school to get to the medicines. And then when he got to the clinic, there was the notice to say he needs to go to the nearest day hospital or clinic that's suitable for him. This was the last weekend, the start of the long weekend. He just run out of medication. So he thought he better get there Monday morning at 1 o'clock just to find out that medication had been that the allocation of patients for that facility had already reached number 15, and he therefore needed to come back the following morning. So he was quite distressed because he then had to disclose to his family GP that he's HIV positive and that he needed to get medication. The concern was that there was no access to information in regards to his viral load, his renal function, also no information regarding his medication. So they had to work it out as to what treatment he needed to get and what he and the way forward. So obviously addressing his internalized stigma, addressing the fact that he was feeling very secure and safe in that space that was made available for key populations, and now he's feeling much more vulnerable and at risk. The second patient is somebody I knew, a 60-year-old patient who I'd been seeing on and off since the late 90s. When I saw him in the late 90s, he had a CD4 count of about 8. And on our advice, he traveled to the United States to get access to therapy, which he did. He brought some back so he could share that with some of his friends. And he's been able to survive to this point on and off, able to access medication from the state. And he then goes to the clinic on Monday. He gets a WhatsApp prescription and advised to go to one of the larger pharmacies to get this medication. And it's going to cost him close on 1,000 Rand because he's got a couple of medications. Also, no idea of what his results are, why he's on a specific regimen, and you know, what's the way forward. So it just highlights the inadequacies of the system we are in at the moment, and it just takes me back to the funding humps we've had over the last 30-odd years of democracy. So in 1994, when Jay Naidu came in with the RDP, a lot of the NGOs were working in this space were closed down because government was going to take on the funding and therefore provide the support that NGOs were doing. And as Kate had mentioned, there's certain things that governments just cannot do. And then in 2003, we had the treatment plan, the first plan put together under the guidance of Mantu Chabalala and Simang. And then after that, that also resulted in a delay because the donors supporting that were not welcome in the country for various reasons. We went through that whole phase of AIDS denialism, and then soon after that, PEPFAR came on board, and there was funding made available to fill the gaps. 2012, Hillary Clinton visited, and that's when the first concerns were raised around funding in the sense of moving from direct service delivery to technical assistance. And then we went strictly to technical assistance, and then realizing very soon after that in fact there needed to be a blend. And then in 2017, when the first Trump administration came in, there was also funding, a reprioritization, and now we have these final cuts. So what it tells me is the fact that we as a country have not really prepared for these kinds of tsunamis. What happens if a war breaks out? How do we get our treatment to 8 million people? How do we improve our access, our manufacturing? It's not only South Africa, it's actually the region. So I see this as an enormous opportunity for us to take stock, understand where we are at, get a clearer picture, go back to where we were in 2003, where civil society was mobilized to put together a very comprehensive strategic plan. And this resulted in a very clear way forward, and looking at the role of CBOs, of civil society, and then managing the approach in a comprehensive way. So certainly we need a rapid situational analysis. We definitely do need the districts to come together to advise as to what the service gaps are, what the HR gaps are, and move to a provincial summary and then feed this back to the NDOH. And this has got to happen very quickly because as Prof. Kevin and Ketan mentioned, with PrEP not being available, with the support for PrEP not being available, with the long-acting PrEP not being studied and implemented, we are going to have a spike of new infections. And then with advanced HIV disease, again, we're going to see another peak of advanced HIV disease. And this is going to lead to us losing ground that we fought so hard for in the last few years. So, so yes, I think this is an opportunity. This is an opportunity for us to see how the NHI can help, how you can have private sector, GPs, and NGOs access information regarding patients who are being managed, and supporting each other in trying to get the best outcomes for our patients. So the impact certainly is going to be on HIV. The concerns I have is also on TB, and soon it's going to be malaria as well. So we are dealing in a very dynamic and fluid situation, and certainly we do need to be proactive. This is a crisis, and certainly people are not going to die tomorrow, but the way one feels is that it's like it can wait. We have other pressing priorities at the moment. I don't think so. I do think we need to be much more proactive. There is not the feeling of urgency. There's not the feeling that people are feeling left stranded, unsupported, abandoned, and one gets a feeling as if they don't really matter in this equation, and I'm very concerned about that. Thanks, Prof. Over to you.
Thank you so much, Ashraf. Do you feel that SANAC has done anything? Where is SANAC in this whole situation?
So, you know, the National AIDS Council really should be able to have a handle on where all the donors are. What's Global Fund doing, what's PEPFAR doing, and have all the data. I don't get the feeling that we have that. We don't have these things at our fingertips. We are kind of muddling around a bit, and therefore our approach to this crisis reflects that. You know, and I just think that if maybe it is the model of funding that we've had, or the model of funding that we don't interfere with other donors, we get on with our own, we are in our own silos, in our own, on our own track. And that for me, when it comes to a public health issue like HIV affecting 8 million people, you can't do that. Not in this country. We've got to all work together. Everybody, you've got to know, you've got to have your war room. You've got to, and this is what we spoke about in 2003 already, a war room where you know what's happening, you follow, you track all that data monitoring, you know, the numbers of people tested, the number of people on treatment, the number of people failing treatment. Where are the weak spots? Where are the weakest links? And what do we do to intervene? How do we then support an area of weakness? And as Kate had mentioned, how do we avoid duplication? How do we also support innovation where innovation has shown to be pretty useful and critical?
Thanks, Ashraf. And it's not like the country doesn't have the experience or the know-how in terms of rapid response. I mean, we've seen in March 2020 how suddenly we saw, what was it, a National Command Council And before the end of the month, I think it was the 27th of March, that we were all in a total lockdown.
Correct. Correct.
So it's not like they don't have the know-how in terms of what to do. You know, the lethargy in terms of their response to this particular situation is really, really, I would think, unconscionable. I hope you can't hear the interference.
No, I can't hear anything. No, just you.
Yeah, we've just had a sudden downpour.
Oh,
So,
no.
yeah, this may interfere with connectivity as well. So I think, Ashraf, we'll have more discussion during the Q&A session on your particular experiences, and I think we need more discussion on how you see what government's responsibilities really are. So I'll move on to Fatima now. And just to, you know, as an introduction, Fatima, I think it's really important for us to understand the history of how international development took place. And that was in the wake of the Second World War, where global powers competed to establish a new world order, and international development started being built up. And with this international development came this international funding as well. And this development has been guided by initiatives like the Millennium Development Goals and the 2030 Agenda for the Sustainable Development. But I think it's also important for us to recognize that governments of main donor countries, we've just had the experience with the US, and we're running to collect EU funding, but they have their own interests in mind when providing funding aid. And these can be influenced by geopolitical, ideological, economic, and social agendas, as we've seen by the latest Trump directive. So there's no denial. If we get funding from anywhere in the world, this is not without conditions and strings attached. So now, how should we respond to this withdrawal, not only of PEPFAR, USAID, CDC, but also now the NIH withdrawal, the bombshell that came through last night. And the reason I want to bring this up as well, the NIH withdrawal, is because while research gets done in South Africa, it has a greater impact globally. And, you know, our contributions have led to global cures, prevention and cures as well. So research just done in South Africa is not only for South Africans, as Trump tries to infer. And also, in terms of research and treatment, today's research is tomorrow's treatment and cures, right? So we can't divorce the two. But Fatima, over to you. Take us through the human rights, the ethical issues, and how you think the situation could be addressed. Over to you, Fatima.
Thanks, Prof, and thanks, Ashraf and Kate and Kevin. And just wanted to start off with just expressing our solidarity and support to all the frontline workers and the patients who are affected by these cuts, and the community monitors who are affected by what is happening in this country. Many people are losing their jobs. Many people have lost their grants. Many people have lost their livelihood. And as Ashraf quite clearly illustrated, many patients are also losing sort of uninterrupted access to essential services, including testing, treatment, psychosocial support as well. So just wanted to relay that we understand and appreciate it's a difficult time. And I think that's why it's even more important for us to talk about this and to urge all relevant role players, including our peers, including universities, including government officials, to stop being silent and to actually speak up and speak out about what the Trump administration is doing, not just to South Africa, but to many parts of the global South too. And I think that I wanted to start off with that because of what happened last night, where we've now been declared as a country of special concern by the Trump administration. And that's what Ames was talking about in relation to the termination, potential termination, likely coming in the next 48 to 72 hours of all NIH grants that focus on South Africa or that focus on China, also another country that's been specifically targeted by the Trump administration, and other countries of concern, according to the Trump administration. So South Africa, if we're talking about South Africa in this webinar, we're clearly in the sight of attack of the Trump administration, but it comes amidst attacks on global organizations that are doing similar work, and it also comes amidst their attacks on science and on evidence, including in relation to groups who are based in the US. The same situation that's playing out in South Africa is also playing out in the US, particularly in relation to groups that are doing work on what the Trump administration calls diversity, equity, and inclusion. But if we come back to the situation of South Africa, I just wanted to make a few points. I want to take you through some of the modeling that Kevin has introduced earlier, why there's a duty on government to develop a plan, and I'll take you through some of the elements of that. What should be included in the plan, what's its duties in line with constitutional jurisprudence, in line with the tech precedent that we had in South Africa, and what we've sort of been through and had to deal with during the HIV/AIDS denialism era. So what are the elements of that plan? And so we can start trying to get some consensus amongst our community on this, and why a plan is important in this particular climate. And then finally, just some recommendations of what we need to do next. So the first thing, and unfortunately, it's not good news, to summarize what Linda Gale and others have done with their modeling, and it mirrors the new modeling and predictions of UNAIDS that they've issued a few days ago as well, is that in the next 10 years in South Africa, if there's no response to dealing with the PEPFAR cuts, so if there's absolutely no funding support, if there's no service response, if there's nothing, and there's different scenarios that they've basically dealt with in their modeling and in their projections, you're looking at a repeat of what we had to deal with in the late 90s and early 2000s. And some of us were all there at that time, and we know what that was like. But you're looking at the possibility of 600,000 deaths over the next 10-year period, possibility of 500,000 new HIV infections. I would urge you to go read the full paper, because I think it gives quite a worrying and quite a bleak outlook of what's potentially coming down the way if we don't deal with this with a sense of urgency, but also with a proper plan in place and with proper funding allocations. So if we come to the issue of the plan, for one, we live in a country with a constitution which guarantees the right to access to healthcare services. So it would, in our view and in our submission, be unconstitutional to stop providing services that have already started being provided in the public health sector with or without PEPFAR support. And I think that's an essential element of any response that we're going to have. You can't pick and choose which services you're going to continue. The point is that these services have been essential for millions of people, and they need to continue in one way or another. The way in which you offer it, where you offer it may be different, but the service has to continue, and it has to be uninterrupted. It has to be uninterrupted also because it has public health implications if you stop taking your ARVs or if you stop taking your TB treatment. There's some new studies that are coming out suggesting what the impact would be in the long term for countries like South Africa that will then face a greater financial burden if you have to start changing people's regimens and have to deal with resistance and with a change in regimens. So the point about the plan is that I've mentioned the TAC judgment. We have precedent for it. We have a constitution. The way in which a plan has to be developed, we would argue, and we've always argued, whether it's in response to HIV or in TB or to cancer or to diabetes now in South Africa, is there has to be transparency in the development of the plan. There has to be consultation with affected groups. And in this particular case, it's all the program implementers, all the NGOs, all the researchers, all the communities, all the patients. And there has to be funding that is allocated to be able to continue with the provision of those services that should not be interrupted. Now, unfortunately, what we've had is something leaning towards the opposite. We've had one circular that's been issued in the space of 2 months, one that has not been fully implemented. And the information on the ground is that it's difficult to implement because some of the legal mechanisms to give effect to dispensing of 6 months supply of ARVs have not been effected and certainly have not been effected in all provinces. So what Ashraf has been talking about, we're getting reports of that from across provinces. And in provinces outside of the Western Cape and Gauteng, we have information that the situation is even worse. We've had one Department of Health meeting, which was hastily called because civil society had a press conference lambasting government about 72 hours before that meeting. It was called on short notice in Pretoria with no virtual attendance, and not all program implementers and NGOs that are relevant to this discussion for a proper consultation were invited. And we have information that there was one attempt at a SENEC civil society forum conversation meeting. It's very preliminary, but again, not all NGOs and not all program implementers were included. And then to top off this very confusing scenario of why it would take so long to have a proper situational analysis, to have proper consultation, to reach out to all the different groups, without just having to rely on media reports, there was a media report, not a press conference, not information shared anywhere else, but a single media report that indicated that the Department of Health had commissioned Deloitte to conduct a situational assessment within a 4-week period. And by our count, that 4-week period is probably over. Now, we don't know if this is correct or not, whether it can be confirmed. Nobody knows if the terms of reference are public. Nobody knows whether if Deloitte, if they have indeed been commissioned to do this analysis and make recommendations to government about which programs and which services should continue and how they should continue, or to give a full situational analysis to, presumably we would believe, lawmakers should be involved in this, then none of us have any information about this. And what we've done as civil society, and I'm taking you through this quite carefully because I want to show you that we've tried to engage on all of this and to ask the questions, but we've had no answer. We wrote to government early on the 5th of February and said, there's a crisis, we need urgency, we would like to all come together, you need a task team, what is the plan? No response. Wrote again 28th February, no response. Wrote again last week, asking questions both to government and to Deloitte and the presidency and National Treasury with the postponement of the budget and then the presentation of the budget that did not mention PEPFAR. It was silent. So all the signs, I think, are indicating that we have an issue with transparency, we have an issue with consultation, and we're going to have an issue with funding to find sufficient resources to be able to fill the gap. 17% is still a country that was the largest recipient of PEPFAR funding, and we've now also learned a significant recipient of NIH funding. By some accounts, about 70% of our research in South Africa on TB and HIV was actually funded by the NIH. So this is going to be devastating for current services, but also for the future management of both of these diseases, which obviously you all know we're the epicenter of that in the world, and it's a co-epidemics. the letters that we've written to government, if you'd like to see that, and the questions that we've asked and takes you through in more detail, because here I'm just giving you the summary, are on the Health Justice Initiative's website. Now, the difference between now and the early 2000s is that government is not in denial of what is happening. It has publicly said and committed to developing a plan. We just don't know who's involved in developing it and what it's going to entail. And I think that's the concern that we all have right now. And so there needs to be two elements in this plan. And we would urge you that if you're speaking to lawmakers, if you by some chance get contacted by these Deloitte consultants, then you need to talk about two elements that need to be included in this plan. The one is that we need an uninterrupted continuation of services, especially for marginalized groups that the Trump administration wants to stop providing healthcare to, not just in South Africa, but in the US and elsewhere in the world, particularly LGBTIQ populations, sex workers, migrant workers, patients who need gender-affirming care. But in South Africa, the services also have to continue for children, for women, for pregnant women, for survivors of GBV, for patients who are living with TB, for counseling support, for treatment, prevention, testing, adherence support. So there's a number of services. When we talk about services, I think government has been so focused on only talking about HIV and TB treatment that they're ignoring the full list of services that need to continue, that I think Kate quite carefully went through in her introductory remarks about the value add that PEPFAR brought in and the type of services and support that needs to be funded, including data collection. And I think there's still a big question mark about all the data capturers that were funded by PEPFAR, the NHLS. So there's a number of elements, and then obviously finally community-led monitoring. But then there needs to be a second element in the plan. I don't think it would be ethical, appropriate, I would also argue not legal, to say that, well, the Trump administration have stopped all the clinical trials or interrupted them, and they will now all just be concluded. There has to be a way in which we address the ethical and the legal duties of government, of universities, of the trial sponsors, and of multinational pharmaceutical corporations that are also co-sponsors of these clinical trials that are now heavily affected by what is happening with the Trump cuts. Because at the center of the trials are trial participants who come from our communities, who basically, for want of a better word, have been the guinea pigs so that we could test a number of clinical interventions in Africa, but then they would benefit people in the global north first. We saw that with COVID, we saw this with HIV, we see this with TB. This is something we can talk about in the Q&A as well. But I think the question to government has to be, are you seriously not going to find the money or not going to find businesses or other contributors, rich, wealthier philanthropists, sort of what people did during COVID, the Solidarity Fund, many other measures that you can take to try and mitigate, at least, at the very least, at the minimum, the impact of trials that have already started but have been interrupted. I mean, I think it's a different conversation for trials that have not yet commenced. But it does mean that for trials that have not yet commenced, what is the future then of TB and HIV research for Africa, for HIV prevention in particular, for women who need key HIV prevention technologies, so that over time we can actually reduce infections and deal with the number of cases that we currently have. And so I would argue that you need to have a plan, you need to include these duties in the plan, because you have a legal but also an ethical duty to prevent new infections. And we've talked about the modeling. We know what the numbers are. We know what's at stake. But you also, as the South African government, have a duty in terms of the Constitution to treat existing infections and to prevent deaths. And I think the death figure in Linda Gale Beckers and others modeling, as well as the new data that's been issued by UNAIDS, is the reason why the death element what of why the urgency, I think, right now is warranted. So finally, I just want to say that 17% is a misleading percentage figure. It's not telling the full story of what is at stake currently, what's at stake, and then what is going to be at stake in the next 5 years, in the next 10 years, in the next 15 years. And so the silence, I think, of universities, of ethics bodies, of others, I think at this point, at 27th March, is no longer, justifiable. We can't understand the silence. I think that there has to be a speaking out on that. And I think there has to be a call and a demand on government, especially the Minister of Health and the Minister of Finance, for a sense of urgency and for a sense of commitment to a more inclusive, transparent process to develop a plan that's rooted in evidence, and to develop a plan that's not just mindful of certain interests or role players' interests, but really takes into account the entire ecosystem of what has just happened in the last 20 years, but more so currently what is happening right now. Thank you.
Thanks. Thank you so much, Fatima. And it's all good to develop a plan, but there's got to be a sense of urgency, like you say. And there's also got to be transparency to the South African society in terms of the development of the plan, and not only to stop at development, but there's got to be that sense of urgency in terms of implementation as well. And with government's track record, unfortunately, some of us already have a sense of despondency when it comes to that. And I really don't know how the situation is going to be handled. But I do believe that we have a shared responsibility, and government must see that. The government needs to share its responsibility with civil society, with the public, the private healthcare sector, or the private sector per se, in terms of working at a solution. We've got the largest HIV epidemic in the world. We can't afford to sit back and have armchair management the way government's doing at the moment. And I think we get together, we have that shared responsibility, and look at how we confront the issues that are urgent for now, and then medium and long term as well. I think that's really, really necessary. But again, is there going to be appetite for this from government? And that's the million-dollar question. But thank you so much. I think at this stage, and I'm looking at the time, and we do have a hard stop at 5:45. So I'm going to hand over to Kevin and ask him to please field the questions that have come up on the chat, on the Q&A actually. Kevin, over to you.
Thanks very much, Ames. But we don't have too many questions yet. So if there are still other questions, please would you send them through? And I see that there are some questions that have been answered already by panelists, and so we won't be responding to those. Pat Sidley mentioned some of the additional cuts that were announced last night. And in addition, obviously, to NIH, there's also the DHHS in the USA and jobs being lost. And she's asking about basically claiming that this is response to this cannot be done just by one individual country, and asking whether we need something like a kind of wartime cabinet with other countries in our response. Any of the panelists like to respond?
Yeah, hi, Prof. Yes, now I would agree that we definitely do need a war room. We do need a strategic approach. You know, years ago, SANAC would put out almost an annual national strategic plan that the Department of Health would present. But we do need this now urgently. We do need as we did with COVID, something that's got to come out within the next few weeks to avoid the descent into all those deaths and advanced HIV disease. So I just think that as Fatima says, the time is now actually, and I can't understand the lethargy and the navel gazing that's happening at the moment. Thanks.
Thanks, Ashraf. Any other comments? Ames?
A comment on institutional responsibilities. We've been talking about government responsibilities, but institutions, I think there's silence that's been deafening, because institutions have really basked on the glory of the researchers in terms of the funding that they've brought in, the research that's been done, which has led to, which has translated into diagnosis, prevention, and treatments. And at this moment in time, I don't think I see that institutional responses that we should see. Having said that, I just think we need to point out the responsibility to the participants in research. So we have research participants that are already enrolled, many of them already having taken interventions. And if the researchers go back to them and tell them that there isn't any funding for monitoring and care, then clearly those participants are going to feel abandoned. Not only feel abandoned, but they are going to be abandoned. And in terms of medical ethics, we cannot abandon our patients. And therefore, you know, if we you know, draw an analogy with the researcher and the researcher participant relationship, the researcher can't abandon his or her participant. And I just want to talk about, and this is what we heard when discussing with some of our researchers yesterday in a meeting with them, the moral distress that they are feeling at the moment. So here we have researchers really morally distressed. And also this impacts on their mental health as well. And our institutions, I don't know if our institutions are putting together something to address the issues with regard to supporting our staff that have been involved in PEPFAR funding together with our researchers in terms of their mental health. I think we need to, I think this is an institutional responsibility. And when it comes to monitoring, I think the institutions need to work with their researchers to develop some sort of framework for contingency planning on how to take forward that necessary monitoring that is required. I think that's really, really important, Kevin.
Thank you, Ames. Yeah, there are a few questions here that I think are quite similar, and so I'm going to read out a few, and then perhaps we can respond to them together. Thanks for all speakers. Arguments are well defined. We need urgent intervention from national government. How can we lobby for this? Surely we have prominent researchers and we can talk WhatsApp groups, etc., with REC chairs, etc. This is a national crisis. And then another one is asking whether there's any communication from the Provincial Department of Health on plans and risk assessment. And then another said that government is dealing with a dual crisis. We can't fund posts. We're looking to remove overtime from healthcare workers to claw back funds. And in addition, there's this withdrawal. And the question asked is, why has this government, the Department of Health, not been placed under curatorship, which I think sort of suggests the seriousness with which people are seeing these issues. Any responses to those?
I think, Kevin, just to say that we've just been so disappointed at the response, which has been from national level in particular, which has just been so dismissive of this crisis. But we've seen it before, that in the NHI is such a focus that everything else seems to lose, not welcomed into discussions, and I think it's a major problem. I just wanted to also speak to the provincial departments, one of the questions that was raised, and to say that there was a great health systems learning webinar yesterday, where a lot of the provincial departments of health spoke to how they are trying to manage this time, obviously with very different capacities and all managing in their own way. So the provincial departments are planning and they are trying for the most part, although there are still some departments who are hoping that funding will return. It's difficult as well with for the provincial departments, with some partners still working, others not, some coming back, some, it is a difficult situation for them.
So, thanks, for the provocation. If I can just add, I mean, we've heard rumors that a plan is being developed. The point of my presentation was to say that, well, none of us are involved in the consultation process and the right people are not being spoken to and there isn't transparency. So the question is, what do you do in a time of crisis when you know that a plan is being developed somewhere behind some closed doors? Is to make as much information publicly available as possible, to speak up, and that's why we're really calling on everybody now to break the silence. Like, the funding is not going to resume. You're not going to be put on a good list by the US administration. There are other geopolitical factors at play. The funding is gone and it's going. Even past expenses may not even be covered. Somebody asked that question. That's what happened with the PEPFAR notices, because it's not in the interest of the US administration has used something not in their national interest and doesn't align with their national security interests of the US government or something like that. So it's really serious. There is going to be no funding from the US government for the foreseeable future, maybe in another 4 years if there's a new administration. So the question is, how should this plan look like? Should we start drafting a shadow plan? I think we should. Can we find somebody who can convene 400 people across South Africa so that we can start giving input into a process that SADC is not including us in, that government is not including us in, and that has left it, we think, to Deloitte, which, by the way, has been fingered in state capture by Open Secret. So there's just, some of the decision-making of government around when it decides to hold a meeting, who it decides to ask for information, who it includes in particular processes is a concern. That doesn't mean that government doesn't care. That's not what we're saying. But what we are saying is that you are at the helm and you're responsible for the country's entire public sector program and also our private sector response. We have a crisis around the continuation of services. We all need to either work together or we have to take our government to court at some point. If there's not going to be sufficient funding, if the plan is deficient in any way, if services are going to be cut in any way, then we will have to see our government in court, because that is what we have as a democracy, because we still have a constitution and we can actually still go and ask for legal protection and relief. The other way in which you can find out what's happening in the rest of Africa, what's happening at the AU level, that's been a question in the box, what's been happening at SADC. I mean, our assessment is very little. There's discussions and conversations and people that, express that, yes, it's very bad and it's very urgent, but the money is not being found. The technical expertise to support these governments to do this is not there, because a lot of these countries were totally totally beholden to the US government for a significant part of their health funding. Even though ours was 17% and we're the largest recipient, if you look at a country like Malawi, 70% of the entire health budget was actually coming from the Trump administration, and they also in the line of attack. So they're dealing with, I think, a more dire situation if you put things in perspective, but we're not seeing the levels of commitment and political leadership that we need at the AU level. What's interesting, and Kate talks about, the early weeks response of government where they said it's only 17%, it's negligible, we don't need the US government. That narrative has changed over the last few weeks too. Yes, it's a crisis. Yes, it's urgent. It's very important. And if you read the Becky Caesar article overnight about what the minister said at the G20 health meeting, that's the first time you actually see him give a very sobering outlook of what the geopolitical crisis is, what the funding crisis is globally. And for the first time, he says, or the way I'm reading it, is he's saying, well, this is definitely going to affect the planning and the funding for NHI in South Africa, National Health Insurance, because there simply isn't money. And I think that's the message that there isn't money. I'm putting that in inverted commas. There is. It's just about prioritization. And we've got to deal with corruption and wasteful expenditure and all of that. But that does mean that there seems to be a narrative shift. I don't know if that's going to be sufficiently positive for what we want out of this process. But I would really urge you, in the same way that we had all of you support us in the HIV/AIDS battles of the late 90s and early 2000s, it's all hands on deck. Everybody contributes whatever they can. We need knowledge sharing and information to try and urge government that has a small team, there's a small research team, to actually come up with a plan that's robust and that can prevent the deaths and the infections that LGB and others have been warning about. Thanks.
Thanks very much. And I think, Fatima, that's a very strong note on which for us to end. Obviously, this is an ongoing conversation. We haven't had the time to really get into it. But I think that the challenge has been heard. And so I think that all of us need to think about ways in which we can consider finding ways to pressure government to start being more transparent about how they are going to be dealing with this, as well as I think it's important for us to express our solidarity to those on the ground who are struggling with this at the moment. Thank you, everybody, for your time once again. And we'll keep you updated if there are any further developments through our channels. And please do enjoy the rest of your evening. Thank you.
Thank you.
Thank you.
Thanks,
everybody.
Thanks, Ames, Kate, Fatima, and